Moving to the next plenary session, which is on diabetes. To chair this session, may I now invite Senior Consultant at Indraprastha, Dr. S.K. Wangnu, sir, and Dr. Deepmala Lalchandani. Over to the chairs for the session.
So we continue with the plenary session, and I am glad to share the dais with my co-chair, Dr. Deepmala Lalchandani. And we had two great lectures in this session. The first topic is the twin cycle hypothesis, basis of diabetes reversal, but none other than Dr. Deep Datta. And the second one is the changing profile of type 2 diabetes mellitus in Shashank Joshi. Now because of the Shashank Joshi has to leave somewhere, so I think we have switched the topic. First I will call Dr. Shashank Joshi. I think I will fail in my words just to describe this dynamic, I will say still the young endocrinologist, though he is so senior, but still looks very young endocrinologist. His BMI never increases, whatever he eats, I don't know why. Like he and the Dr. Yaznik, both are having the same BMI. I don't know what genetics is playing their role, and he is the right person. He is a well-known figure, a good orator, the most sought out of a speaker, the king of Mumbai, Shah Rukh Khan, Mumbai. And Padma Shri Dr. Shashank Joshi talking on the changing profile of type 2 diabetes. Over to you, dear.
Thank you, Dr. Wanganu. I must first congratulate this whole team, SPEEDCON and SPEED. Sameer, Atul, Deepak, Vineet, Deep, Rajiv, Saptarshi and Sanjay. I think you all have done a fantastic job, and I think it's delightful to be back. I think please put your hands together for the entire team. I think the SPEED team is outstanding, Wherever you are, I think we were fed up of this whole virtual thing, and I'm happy to be unmasked and happy to be standing in front of everybody physically. Because I think it's time to get physical again. And that might be a very different thing. Moving gears from B12, folate, microbiomes is again, the untold story of type 2 diabetes. It's an enigma. And I think my first part of my talk, before I start my slides, is a oration which Dr. Kalra gave. And he said that there are 7 phenotypes of diabetes which we see in a clinic, in a practitioner in India. We see a very lean phenotype, we see an underweight phenotype, we see a normal weight with abdominal obesity, we see a normal person, then we see an obese and a morbidly obese. So we see that whole spectrum in our clinic. And we see people with type 2 diabetes across spectrum, right from the age 12 to 100. So again, we see the full profile which is changing, and that whole thing has gone into now clusters. So I'm trying to connect some dots. There are some distressing slides of the IDF Atlas. I represent Southeast Asian region. And in 2019, when the Atlas was published, annually 4 million people were dying due to diabetes. Or that's why attributed to people living with diabetes. And what is very distressing is, despite of all these advances in medicine today, 6.7 million is the number. So number has actually gone up. So there's a lot of industry outside. They say they save lives and save heart and kidney disease, etc. This is a very distressing slide. 1 in 10 adults have diabetes worldwide. 1 in 18 have IGT. 3 in 4 people live in countries like ours, middle income or low income. 1 in 2 don't know they have diabetes. 1 in 6 live births are affected. In India, it's probably 1 in 4. 9% of global expenditure is on diabetes. but still 6.7 million. Can we make a change on the mortality? And India really peaks up there. And you can see the increase in our region is 68%, Southeast Asian region. So that's not very great. Compared to that, Europe is only 13%. Western Pacific is only 27%. Africa is really exploding at 134%. And Middle East and North Africa is probably the biggest hub of a very explosive pandemic. But obviously in type 2 diabetes, it's all about clustering. And this is a paper from Philippe Frogel from France, which Dr. Yagnik knows very well, that type 2 diabetes is a very heterogeneous disease. There's a lot of phenotypes and genetic clustering. And that clearly, has evolved into a specialty called now precision medicine. And Deep, I'm thankful to him that he exchanged the talk. He's going to talk on how diabetes can be remitted in some of those clusters. It's doable. So obviously now the future of precision medicine in type 2 diabetes is all about cluster or subgroups within type 2 diabetes. As clinicians, we have to identify those subgroups. We have to look at features beyond just waist circumference. We have to look at C-peptides. We have to look at insulin resistance, and we have to migrate and cluster and have those novel clusters in our population. So obviously people are looking at molecular signatures in clinical clusters, because we are all clinicians, we all see patients and people living with diabetes. And obviously, are there distinct molecular signatures in a multifactorial disease like type 2 diabetes? Because we clearly know that such molecular signatures exist. A lot of works have gone in genomics, on metabolomics, lipidomics, proteomics. And we can actually map all this and cluster this. And that research is ongoing. So one of the earlier clusters which came from the Danish cluster, the DD2 cohorts. And clearly you can see from that data-driven cluster Danish studies, clearly you can see that when they were looking at Swedish clusters, and we'll come to Indian clusters, they looked at age at diagnosis. Clearly, whenever you see a patient in your clinics, look at the age in diagnosis, look at the BMI and waist circumference, look at A1C, look at HOMA2 as an estimate of insulin resistance and beta cell function. And then stratify phenotypes. And in the Danish study, they had 3 type 2 diabetic phenotypes based on HOMA2, insulinopenic, which means beta cells don't work well, too much of insulin, hyperinsulinic, and the classical phenotype. That's how they started this whole clustering phenomenon. Of course, Scandinavians went one step further, and I'm not putting them out there. And obviously our phenotype is different. Dr. Mohan and Anjana put out this, and a couple of years back, we also put out a small little thing that South Asians, where we live, clearly have some phenotypic differences. Dr. Vyagnik has done some very elegant work, and in that paper, there are clear issues in India on DNA methylation, histone modifications, microRNAs. Clearly it's familial. Clearly there are environmental impacts and epigenomic impacts on type 2 diabetes in our phenotype. And clearly we are a starch country, we are a starch and carb and fat country. Clearly we see that very, very obviously. And we definitely have a high carb intake. 2/3 of our meal lead to that prandial glucose curve, and that definitely works on our phenotypes. And clearly the relative contribution of prandial glucose to A1C, Indians versus Caucasians, this is all a collated literature, and some of the authors are in the audience here. Clearly you can see that we have that prandial excess compared to the Caucasian world. So clearly there. So obviously if you look at our phenotype, we are thin fat, abdominally fat, more insulin resistance, a lot of inflammation, low adiponectin, typical dyslipidemia of low HDL, high triglycerides, and clearly susceptible to coronary artery disease. So obviously Dr. Mohan did a lot of work on furthering these subgroups. Dr. Yagnik has published papers, many have published papers in this direction. They looked at this inspired study, and let's look at those clusters. They identified 5 clusters, but they were different from the Scandinavian or the European clusters. So if you look at this is around 19,000 plus population, 8 relevant variables: age at diagnosis, BMI, waist circumference, glyco-HB, triglycerides, HDL, C-peptide, fasting and stimulated. You can use either glucagon, you can use a simple morning breakfast. And from that, there were 4 replicable clusters which was identified by Mohan's group, 2 of which were very unique to us as Asian Indians. And they also described a novel cluster, which was a combined cluster where we get a combination of both severe beta cell deficiency as well as insulin resistance. So they called it as a combined IRDD phenotype. And this was a brittle phenotype. It's difficult to control hyperglycemia. And they are particularly vulnerable to renal disease and retinal disease. So if you see such patients in your practice who suddenly get rapid deterioration in their renal function, retinal function, brittle diabetes, and a combination of resistance and deficiency, that's the cluster their group describes. So they have actually stratified it. And obviously, the way we treat clinical practice will change in the future. Research will evolve, but research is now giving us some directions for clinical practice. And that's really the idea of this talk when the SPEED group asked me to talk on that. And we clearly have some insights now. We have some insights from some groups, and I'm not biased to a group A or a group B, but we have some insights now. Like QS 158 paper very clearly tells us the future risk of diabetes among Indians with metabolic and phenotypic obesity. Because we clearly have in India MHNO, MHO, MONO and MOO, which means that we have metabolically healthy non-obese, we have metabolically healthy obese, we have metabolically obese non-obese, we have metabolically obese. And we have all these subtyping. And we clearly know that increased BMI and metabolic risk factor clustering contributes to type 2 diabetes risk in these individuals. And clearly, if you further these clusters, we also have risks where there is an increased clot or bleeding risk and ischemic risks with acute coronary syndrome. And this is now worldwide known. This is the START antiplatelet group, which clearly from Italy showed that very clearly. Is this cluster, a lot of people say these clusters are only urban clusters. They don't apply to rural India at all. Because that's the typical, Dr. Marwa is here, he sits on the ICMR, they will always ask you, this is only for urban, this is only seen in a urban environment where Saptarshi is sitting or Deep is sitting and not seen in rural India. That's not true at all. Even within the rural India, you see some clear-cut distinct pathoclinical clusters among people with uncontrolled type 2 diabetes. So again, from same group, I have insisted on the same group because Chennai has done a lot of work in that direction and they have published some good quality evidence in that direction. Clearly you can see that you do see a cluster where you do see uncontrolled diabetes, but you also see hypertension with it. So it's like a twin phenomenon, a combination of hypertension, diabetes and obesity, which is seen, and 3 clusters which are obtained in the rural areas are age, type 2 diabetes duration, comorbidity and beta cell. Dr. Ramchandran's book also published a trend analysis of clinical profile of type 2 diabetes in India, and they looked at anthropometry, blood pressure, glucose control, lipids, treatment options and comorbid conditions. And then they looked at gender also, and they looked at different panels of treatment used, whether it was single drug, multiple drugs, dual drugs, OADs, and how people have delayed actually glycemic control. Their observations were very clear from Ramchandran's group, Ramu's group, that more younger people with obesity were getting diabetes, which is type 2. Multiple drugs were being used, A1C was coming down, but blood pressure was creeping up as an important comorbidity as well as dyslipidemia. So the ABC was coming out quite closely. Recently the ICMR 13 study from the INDIAP cohort also came out in the Lancet. I have not used that in this analysis here. And IJM also publishes very elegant paper of the temporal association in urban India between diabetes, obesity and age of onset. So clearly it's happening. And if you look at the subset analysis, it's all about recent onset diabetes with BMI data. So clearly that trend is seen very, very aggressively. So clearly we can see that. So Dr. Mohan put out this very nice article on what are the Indian clusters. Do we have data on Indian clusters? Well, they looked at 32,000 plus cases. They clustered them over the last 7 years from 15 diabetic clinics across India. And they looked at 2-year follow-up and their drug response. And they found that there was a male preponderance. Average age was around 45. A1C was around 8.9. And same replication was seen of the earlier 4 clusters described in India. Which were those clusters? 40% had mild age-related diabetes clusters. 27% had insulin-resistant obese clusters. 21%, significant, 1 in 5 patients have severe insulin-deficient diabetes. So they don't have beta cells on board. And a small percentage has that brittle cluster of the combination of insulin resistance and insulin deficiency. So these are the typical 4 clusters, and they all responded to the standard of care drugs clearly. And clearly they concluded from their study, Dr. Mohan's group, that we do see these clusters and we need to do RCTs on the drug differential response with each of these clusters. And obviously we need to do risk factor based clustering in a hierarchy with age, gender, BMI, hypertension and family history of diabetes, and look at it further, use some artificial intelligence and look at larger databases. And therefore they did some such database analysis, because now with the current big data one can do a lot of AI and one can look at couple of things. So simple conclusions are that when you are looking at type 2 diabetes today in India, it is very heterogeneous. Every type 2 diabetes is different. Though we have a so-called Asian Indian phenotype, we know we are only thing that it tells us is we are more susceptible to develop type 2 diabetes than white Caucasians, that's all. But there are a lot of subclassifications and clusters and subtypes which behave differently with clinical presentation, have a different risk for developing complications. So these two things are clear cut, and we need to do prospective cohorts, and some people including Dr. Tandon's group etc. are involved in some of these very elegant cohorts which are being there at Dr. Mohan's group, and they are trying to establish some connect there. The unique clusters from the Scandinavian population are well known. The severe autoimmune diabetes, the SIDD, which is the severe insulin deficient diabetes, the SIRD, the severe insulin resistant diabetes, the mild obesity related diabetes, the MOD, and the MARD, the mild age related diabetes. Obviously we can see that within India also at least 4 are replicated, which is SIDD, MARD, IROD, and we have that clear unique cluster of combination of IR and DD, insulin resistance and deficient diabetes. So clearly we'll have to get into a cluster mode. So tomorrow when you see your patients in your clinic, try to see where they fit. Are they fitting into a simple MOD, which is mild obesity related? Are they fitting into a simple elderly 75-year-old adult with a little bit of impaired glucose tolerance, mild age-related diabetes? MARD and MOD is the most common. Are we seeing severe SIRD or SIDD, or are we seeing this 10%, 1 in 10 CIRDD, which is the combination of IR and DD? Obviously, they have different subtypes, different treatment options, predictions and prognostic models are different, and this is the first step towards precision diabetes. So obviously it's a lot of work in progress, and though we have a phenotype which appears to be sarcopenic, low muscle mass, we have put B12 up board there. I'm sure Dr. Yagnik will be happy to see the B12 and D is right up there in our phenotype evolution. We clearly have inflammation, increased obesity, NAFLD has come up in a big way. Low birth weight and thin fat Indians, as well as low age of onset of type 2 diabetes, are right up there in the phenotype evolution. Lower threshold for BMI, insulin resistance, rapid beta cell decline, low adiponectin, and also differences in gut microbiota. So I'm happy that I'm actually given an opportunity to speak after Dr. Yagnik, because if you see what he was showing in the research mode already is in the clinical zone mode and in our phenotype as we evolve. And clearly these are the 4 subtypes in the Indian population, which Dr. Mohan's group, with a group of many of us, try to evolve and analyze. SIDD, severe insulin deficient diabetes, early onset of diabetes, relatively low BMI and waist circumference, low HOMA beta IR, low C-peptide, high A1C, retinal risk, SIDD, 1 in 4. Of course, this is work in evolution. These are early data on clusters. I'm sure you all will have clusters in your clinics. Then IROD, insulin resistant obese diabetes, 1 in 4. I'll just take a minute more. Insulin resistance and deficiency, high BMI and waist circumference, high C-peptide, renal risk. Again, I'm sure you see this in practice. Then of course that severe subtype, which is combined insulin resistant and deficient diabetes, lower age of onset, younger individuals, lot of insulin resistance. It's an intermediate between SIDD and IROD, high triglycerides with low TGs. Often they have a retinal and a renal risk. And then of course a large garden variety which is mild, 1 in 3 probably, with highest HDL, preserved C-peptide, mild diabetes and low risk of complications. And that's how the evolution of complications occurs. So obviously clustering of diabetes is the changing clinical profile. It allows you to classify diabetes, allows us to plan treatment options better, prognosticate better, and probably this is our first step towards precision diabetes medicine. And that's how the clock will tick in precision diabetes in the world today. Thank you for a patient hearing.
I think, thanks Shashank, I think we are moving towards a precision medicine, and near future you will get prescription from the healthcare providers, what type of cluster it fits in, and what kind of a therapy you will need, depending on the clustering of the particular type of diabetes. And I heard that Mohan has developed some app to look and enter the data, and then it will give you what cluster this patient is falling and what medicine is going to be helpful. So that was, I think, Dyna app, which I heard in the API.
Yeah, so there are many apps like that, but we again, as I said, before we develop an app, we really need to reproduce these phenotypes in our practices and publish more data across India. And I think that's the real way to go.
Number second, do you think there has to be a nationwide study?
I think so.
Rather than they focus in one place of the country.
Absolutely, we will need to do a
Before
larger.
we just come across that these are the 5 clustering, because they might differ in different states of the country.
Absolutely.
Yeah, we are just having. Post-COVID, any
So
unique
is there a
clustering?
COVID cluster?
Yeah.
Is that what you're saying? Probably there is a increased recognition of glucose and a poorer control of glucose after COVID. That's a given. Whether the COVID virus per se is, SARS-CoV-2, does it have a relationship with the beta cells? Probably not. The current data is suggesting that the cofactors in the beta cells may have some challenges. So, but clearly we are seeing even the death data which is reported, a lot of the 6 points, plus million deaths which have occurred, COVID did have an impact. So one thing is sure, that COVID unmasked a lot of latent diabetes and made it overt. But we will still need a decade more to really come to some conclusion about a direct relationship. Yeah, but as I said, there's a lot of data on that. And as I said, that COVID definitely unmasked a lot of latent diabetes, particularly with the use of steroids in severe disease. But whether in mild or asymptomatic disease, is there any correlation? We don't know. We'll need to see its work in progress and evolution. Dr. Yagni?
Last, yeah.
Shashank, for me.
Yes.
Dr. Yajnik, voice is not clear.
I thought you would have talked because you were talking before us.
B12, it was all B12, and B12 very interestingly, the genetics of the secretor status which I showed actually is linked with one of the subtypes. And for those who have not read, we have published a clusters paper with LAIF group 6 months ago in people who were diagnosed with diabetes before 45 years of age. So it's in young, where I thought clustering was more relevant than the older people. Not that it's not important, but it's more important here. And we reproduced the clusters in the Indians, compared them to Sweden's, and the difference was that the SIDD, which Dr. Shashank showed in Mohan's paper to be 25%, in those who were diagnosed below 45 years, it was about 65%. It was in Pune, it was in Ahmedabad with Banshi Sabu's data, and in Assam it was 70%. And I have just now submitted a paper on diabetes in Assam Medical College, where the average BMI of the type 2 diabetes patients diagnosed before 45 years was only 23. And even more interesting, on DEXA, they did not have more adiposity than the non-diabetic people. This is the extreme lean phenotype, and I think actually I was driven by that because I sat as a co-chair on the Young Diabetes Registry. We have now genetics of these subtypes, and as I showed you in one, the last slide showed actually that B12 related genotype of secretor status is associated with MODY. I'm sorry, not MODY, MOD, MOD, mild obesity related. And that seems to be more common in women who get diabetes before 45 years of age. So a lot of interesting pathophysiological things are going to come. And as Shashank mentioned, it's going to be precision medicine. But I'm very fond of saying that precision medicine is with good clinicians like Dr. Wangnu or Dr. Shashank, who put their hand on the pulse, examine the patient, ask the family history, ask the past history, and a life course history. Then they know more about them than just calling them something.
Absolutely.
So
but
that's fine. Thank you.
I think that's a well taken point. That's why I said that our phenotype now involves history taking of low birth weight also. Any more questions?
No, thank you, Shashank. We are running late.